Good morning. Everybody's ready with a cup of coffee and whatever you need to finish your breakfast. But it's time for us to get started. I'm Del Elliott. I'm the founding director of Blueprints and the principal investigator on the Blueprints initiative. So it's my pleasure to welcome you to the 2018 Blueprints Conference. We're looking forward to 2 days of great time to look at programs that work, that are effective, and all of the issues that surround delivering high-quality, effective programs to our children and youth in this country. There's a great need, as I'm sure all of you know, for us to be able to provide things that work for our children and families. It's also my privilege here as a beginning to introduce David Hawkins as the keynote speaker. I just want to warn you that in case it doesn't look exactly like David Hawkins, it's as close to David Hawkins as we could get. So it's a great privilege for me to introduce as our first keynote speaker, Professor Jeff Jenson. Jeff got his PhD at University of Washington in the School of Social Work. David Hawkins was his faculty mentor there. So that's the first connection. That's one that's very great. The reason for this change is that David was out on Vashon Island. He has a home out there, and he was out pruning his pear tree on one of these three-legged ladders and fell off. He fell 10 to 12 feet. He broke 3 ribs and 2 vertebrae in his neck and had a concussion, and he was out there all alone. So I think I have to say that I'm just grateful that he's okay. But if you know David, he, in his rigid collar that he's having to wear and all the pain that he's going through, was planning on coming anyway. He had that strong a desire to be able to talk to you. He was excited about it, and he was talking to his friends about it. So I want to convey to you his regret in not being able to be here, because he had greatly looked forward to that. So we have Jeff, who is as close, as I said, to David as we could find. Jeff's work is primarily in the application of the public health model, an approach to looking at child and adolescent development and problems related to their development, and the evaluation of preventive interventions that are promoting healthy youth development. Jeff has 7 books and numerous articles and chapters, all of them dealing in one way or another with child and adolescent development and prevention science. So the most recent books, he has three that are fairly recent. The Preventing Child and Adolescent Problem Behavior, Evidence-Based Strategies in Schools, Families, and Communities was published in 2014. Social Policy for Children and Families, A Risk and Resilience Perspective was published in 2016. And he's a co-author on a book forthcoming, Unleashing the Power of Prevention, a framework for helping community states implement evidence-based interventions. Jeff has received the Best Edited Book Award from the Society for Research on Adolescence. He's received the Aaron Rosen Award from the Society for Social Work and Research. He's chair of the Coalition for the Promotion of Behavioral Health. He's a Society for Prevention Research board member and treasurer. He was in the past. And he's a fellow in the Society for Social Work and Research and in the American Academy for Social Work and Social Welfare. So Jeff and David had worked together on this project, which is going to be reported on here this morning. So I'm really grateful that Jeff was able to come, that his schedule was clear. He's clearly qualified to speak on this issue, and I think is as close to David Hawkins as we could get. So welcome, Jeff Jenson.
Thank you very much, Del. Good morning, everybody. I'm really happy to be here. Del's given you the story on David, and certainly we miss him here today. I know he has many friends and colleagues here. I was just chatting with Gil Bodfin a second ago, and when we were laughing that we've heard of people trying to use excuses to get out of keynotes or presentations or whatnot, but we've never heard anybody go to the extent of falling out of a tree out on Vashon Island. So, but I am here to say David's going to be okay. And I did want to acknowledge him. Here's a photo of him in case you forgot what he looks like. So I want to thank David for helping put this presentation together and acknowledge our steering committee as well from the Coalition for the Promotion of Behavioral Health and several people at the Social Development and Research Group at the University of Washington. Shelley Logan, Blair Brooke Weiss, and Laura Hogan also helped put this presentation together. As you could guess, it was a rather last minute kind of scrambling to get here today. But I'm delighted to be here and talk about some work that we have been doing collectively under the guise of the Coalition for the Promotion of Behavioral Health. And I'm going to be talking about a report that we have published and put together. It was published by the National Academy of Medicine in 2015 called Unleashing the Power of Prevention. And this report has a framework that includes 7 action steps and goals, and I want to report that, essentially describe that to you, and talk about progress related to those 7 action steps and goals. So really the underlying question guiding my talk this morning is how far have we actually come in advancing prevention, practice, policy, and science? And I want to accomplish or cover this rather broad question by looking first at a brief review and evolution of prevention and where we have come. I want to talk about these 7 action steps and goals that form the basis of unleashing the power of prevention, and then assess progress in reaching those goals. So that's my first kind of objective today. Am I feeding back a little bit here? Is that a little loud? And then second, I'd like to make a call to action to each of you to think about how you can be involved in promoting prevention. Obviously, you're already involved in promoting prevention, and that's why you're here. But I'm going to provide a little time towards the end of the of this morning's session for you to interact at your tables and look specifically at these 7 action steps in unleashing the power of prevention, and ask yourself how you can fit into one of these steps and contribute to the work that we are collectively doing in the field of prevention. So those are my objectives for this morning. So how far have we come in our field of prevention, practice, and science? We can start a review certainly in the 1970s. We began to prevent drug use and delinquency in young children, or roll out strategies to do this in the 1970s. And these were of 3 different types typically. We began by providing information to kids in school settings, information about the dangers of marijuana use, alcohol use, driving under the influence, and so forth. If you're my age or above, you probably remember some of these information strategies. And in my case, it was my gym teacher relaying, my physical education teacher relaying these strategies to us. Of course, this information to us, he really knew nothing about it and was rather sheepish about informing us about it and so on. And we'd listen to him and see the movie about drinking and driving and marijuana use. And then after class, we'd be out in the hallway and we'd be saying, wow, that was pretty cool. That was pretty interesting. You know, and in some cases, it cited more interest in the behavior than it did in preventing the behavior. So we started with this in the field. We also rather simultaneously had what became scared straight or fear arousal strategies, the idea we could expose young people to hardened criminals or addicts with the hope that they would see the very adverse negative consequences of that exposure and not engage in those behaviors. And we had Just Say No campaigns focused around substance use. Unfortunately, none of these strategies really produced positive outcomes, and you probably know this story. We didn't see decreases in drug use or delinquency as a result of these early efforts. Some programs, information programs, actually increased drug use, and Scared Straight was associated with increases in delinquency over time. So we begin at that point with an important lesson, and that being that untested good ideas, well-intentioned ideas in each of these cases, I'm sure, can actually make things worse sometimes. So we learned from those early experiences and had a significant paradigm shift then beginning in the 1980s, in which the field of prevention began to integrate lessons from public health and to think more about the idea of prevention being based on a public health framework. And really, quite logically, it started with this very simple idea. To prevent a problem behavior before it happens, you have to address its predictors. So we began to assemble a body of research on predictors of different behavioral health problems like substance use, delinquency, aggression, school dropouts, so forth. Commonly now we view those as risk and protective factors, and it's been several decades now since we've established a body of work that identifies risk and protective factors for a variety of behavioral health problems. And I suspect most of you in the room are familiar with this framework. These are factors that elevate the likelihood of problem behavior or that buffer or reduce exposure to high levels of risk in the case of prevention. We know that these factors are embedded in a social context, in individuals and peers, in school settings, and in family and community settings as well. Also importantly, many of the same risk and protective factors predict different behavioral health problems. So we have this idea, this notion of shared risk and protective factors, in which we know that many of the same risk factors for, say, substance use also are related to problems like school dropout or aggression or delinquency. And there's great sources for you to find more information on risk and protection, and I suspect many of you are familiar with this model. The third feature of this, the third component really of this shift to thinking about prevention from a public health framework is the logical third step in taking knowledge of risk and protection and developing interventions then to change those malleable risk and protective factors, which we've seen occur in the past several decades. So we're at a point now where we can say that really all of these behavioral health problems you see on the screen have been prevented in controlled trials in the last several decades. We could look at mental health problem symptoms, for example, like anxiety and depression, alcohol, tobacco, and other drug use, the set of behaviors in antisocial behaviors and delinquency, aggression, violence, as well as school dropout and other forms of risky behavior, risky sexual behavior, risky driving, and self-inflicted injury. So we've had success actually through the application of a risk and protection model, the development of interventions based on those risk and protective factors, testing of those interventions, where we're now at a point in our field where we can say comfortably that we know how to prevent these problems and that we can prevent these problems when tested and effective programs are implemented well. We also know that some programs have the advantage of preventing multiple problem behaviors. So we've found over the course of the last several decades with some of our earlier programs that they have beneficial effects not only on the key outcome they're targeting, but also on other behavioral health problems. And this makes perfect sense if you think about the idea of shared risk and protection and how a program that's aimed at preventing substance use, for example, may also have positive effects on other forms of problem behaviors that kids have. We put up a few examples of programs here. There are others certainly that we could. These are programs pulled from the Blueprints registry. So for example, life skills training, we see that it was begun really as a tobacco prevention program. Over time, it's evolved to address other problem behaviors, and we see positive outcomes in 4 of these 6 problem behaviors. And you can look at the others as well and see multisystemic therapy having good results on a range of different behavioral health problems. So today we've had controlled trials that have identified over 80 effective policies and programs for preventing behavioral health problems in young people. We can look to different sources for these programs. We always, in our coalition and all the work we do, promote the Blueprints registry as the first place to go to learn about effective programs, and I'll say more about that a little bit later in the talk. Currently on the Blueprints registry, there are 15 Model Plus programs and 66 promising programs. We also know that there is increasingly good work being done on testing the effects of policies aimed at reducing and preventing behavioral health problems in young people. Things like limiting access to alcohol use, things that fall more into the environmental kind of strategies that communities are starting to use, and so forth. The recent Surgeon General's report has a great chapter on this, on prevention, and that reviews policies and their effectiveness. And finally, we know that effective prevention saves money. We've learned over the course of time, primarily through the leadership of the Washington State Institute for Public Policy, who has done some very good cost-benefit analyses showing the effects of prevention programs, not only in terms of effectiveness, but in terms of their cost-effectiveness when compared to more costly treatment and incarceration-type alternatives. So we've learned also there's certain principles that we can bring forward when we talk about scaling up programs, and you'll hear me talk about this a little bit later in the unleashing action steps as well. we're at a stage where we're very logically at the point where we're trying to scale up tested and effective prevention programs. This has been going on for some time. But what have we learned from prevention science to bring forward in terms of scaling? Well, one is to reduce risk and enhance protection. We know that's an important key element of preventing behavioral health problems in young people. We know it's important to choose and implement policies and programs that are proven to work. And we also know that we can have a greater effect when we combine evidence-based programs and policies in some fashion. So we've come a long ways. That was a very kind of brief review of progress in prevention science, but you can see we've certainly come a long ways since beginning this work, say in the 60s and the 1970s in particular. But despite all this progress, we still find that effective interventions for behavioral health problems are still not widely used in the country. That is oftentimes we find in many school and community settings programs that are untested, programs for which we don't know their effectiveness are being used more widely than tested and effective programs. And that we continue to invest as a nation much less in prevention than we do in treatment or law enforcement. This slide illustrates that latter point. If we look at federal drug control spending between 2008 and 2017, you'll see the blue bar on this figure showing dollars allocated toward prevention compared to the orange bar shows money spent towards treatment, and the black bar money allocated for law enforcement and interdiction efforts. And you see we're kind of the stepchild there. We're low on the bar, and it's continued to be that way through this past decade. And you'll note one other thing. The funds allocated towards treatment began to rise in 2014 and have increased a bit each of the past 4 years, perhaps in response to some of this in response to the opioid crisis that treatment dollars are flowing to. But the point being, we're still low in comparison to federal dollars that are allocated toward treatment or towards law enforcement. We could also look at this issue of state funding and priorities for prevention by looking at state budgets. And I'll just give you one example of this from some work that David Hawkins and I have been doing in Massachusetts in the past year. This slide shows spending on prevention of behavioral health problems in Massachusetts in fiscal year 2018. And really what it suggests or shows to you is that less than 1% of funds in the mental health department, the elementary and secondary education, and the early education and care departments in Massachusetts, less than 1% of their budget is really allocated towards prevention activities in comparison to other forms of services that they're providing. So we see a continued pattern in which dollars allocated to prevention are much lower than those allocated towards prevention, towards treatment or incarceration or law enforcement. So how do we ensure the healthy development of all youth? Really, what we're putting forward, the Coalition for the Promotion of Behavioral Health is putting forward, is to unleash the power of prevention, use the evidence of prevention more collectively and in more intentional ways to increase our impact on public policy and funders and on practice in the field. So I want to turn to the Unleashing the Power of Prevention report and tell you a little bit about what its goals and action steps are, and then report on progress that we think aligns with the field, or that the field has made that aligns with our action steps. This was a paper that was published by the National Academy of Medicine originally in 2015. It was also selected as one of 12 grand challenges by an initiative of the American Academy of Social Work and Social Welfare. We have 2 primary outcome goals in a 10-year decade, so these are big picture goals that we'd like to see movement on. One is to reduce the incidence and prevalence of behavioral health problems in young people from birth to age 24 by 20% in the next decade. We think that's doable with the implementation of the steps we've outlined in the plan. Second, to reduce racial and socioeconomic disparities in behavioral health problems by 20%. We know there are significant disparities by race and ethnicity, gender, and income in many of our behavioral health outcomes, and that's a critically important area of work that we need to much more focus on. So we're looking at 7 different action steps to unleash the power of prevention. So let me share with you quickly what these action steps are. I'm going to put them up and then come back to them. So I'll just run through them quickly. And as you're thinking, really how these action steps were created was by a group of us who came together and really just asked the question, what would it take to bring prevention to a higher level of focus in the country and to a greater level of impact? So that was really kind of just the underlying question that led to the creation of these 7 action steps. First, we think it's very important to increase public awareness of the advances and cost savings of prevention. Second, we think it's critical that we increase the percentage of all public funds that are spent on prevention. I talked about that just a minute ago. I'll return to each of these, so I'm just going to run through them quickly so you have a sense of what they are. Third, to implement capacity building tools that guide communities to do 2 things: to assess risk and protective factors in their local settings, and to select evidence-based prevention programs and policies based on those risk and protective factors. 4, establish criteria for preventive interventions that are effective, sustainable, equity-enhancing, and cost-beneficial. 5, to increase infrastructure to support the high-quality implementation of preventive interventions. We're going to talk more about each of these in just a moment. 2 more, 6, to monitor and increase access to effective prevention programs, preventive interventions. And 7, to develop a workforce that is trained in principles of prevention and ready to engage in practice and policy efforts. Those are the 7 action steps. I don't expect that you have memorized those just in that moment, so I am going to come back to those. Those are all in our report, too, that you'll get slides of this later, and I encourage you to look at on your own as well. But let's think about this a minute before I go into assessing progress of what we've made. I'd like you to just self-reflect for a moment. Later, I'm going to give you some time to talk at your tables about these action steps. But as you hear me go through the progress that we've aligned from the field to these action steps, think about what's missing. Are there action steps in addition to those 7 that you're going to hear about and I just listed that you think are really critical and that we're missing somehow? And then secondly, as a call to action, I'd really like you to think about what you could do to advance 1 or more of these action steps. So really our goal is that you become involved in one of these action steps if you are not already, or you think of a different action step and bring that forward to us. We'd love to hear about that. So we'll have a little time at the end of the session for you to report back on what you found at your tables. Secondly, we'd love to have people join the Coalition for the Promotion of Behavioral Health, the group that David and I have been leading along with others from an interdisciplinary group across the country, and have you contribute to those efforts. More about that later. So let me turn to this question of how far have we come in advancing prevention, practice, policy, and science. And we're going to look at this question through the lens of these 7 action steps of unleashing the power of prevention. So, our first action step, as you remember, was to develop and increase public awareness of the advances and cost savings of preventive intervention. So we've set a goal with each of these steps. In a decade, a majority of the U.S. adult population will report in surveys that it is possible and cost-effective to prevent behavioral health problems. So this goal this action steps gets at the broader issue underlying prevention and its support for prevention in the general population. And if we look at data that addresses this question of public perception, we can conclude, perhaps tentatively, that in many ways we're already here. We've already reached this goal. Surveys have shown in the last several years that most Americans favor prevention, when asked about its importance. Here's some data from a 2009 survey, for example, in which respondents 76% supported more investment in prevention. 72% believe prevention is worth it, even if it does not save money. We know it does save money, but even if it does not save money, people recognize the value of prevention in preventing certainly things like diseases and to a large extent behavioral health problems as well. 70% reported in 2009 in a national survey they believe prevention to be the top health care reform priority of the country. So there's really two questions that kind of beg to be answered here, and I'll put them out there and not necessarily answer them today. But if the public already favors prevention, which it appears it does from national surveys, why isn't evidence-based prevention the foundation of healthcare spending rather than an afterthought? So think about that a little bit, and we'll come back to this towards the end of the session. And second, it really begs the argument or the question, how do we activate public support for prevention in a way that turns it into demand? So when we talk about demand, how can we convince legislators, other public funders, some of the more important institutions in our country to really get behind prevention in a more intentional manner and put funding behind it and other supports behind it. So creating demand is another important issue, I think, that we have to struggle with going forward and find solutions to going forward. Our second action step was to ensure that 10% of all public funds spent on young people's well-being would support effective prevention programs. This is a fairly modest number, but as I showed you earlier, with the level of prevention spending in the country at the federal level, we're below 5%, certainly. So this is an action step that we had. We had a goal that at least 10% of state and federal expenditures would go towards effective preventive interventions and policies. We've been looking at assessing progress of this step and goal in several different ways and trying to align again what the field has accomplished in terms of its match to that action step and that goal. So we can look at federal legislation. We've pulled out just two examples that we think illustrate supporting prevention efforts in children and families from the last 2 years, actually, and we could go back further in time. But we have seen passage in the last year of the Healthy Kids Act, which provides 6-year funding extension for the well-known Children's Health Insurance Program, or CHIP, and passage of the Family First Prevention Services Act, which provides mental health, substance use treatment, and importantly to prevention, in particular in-home parenting services to families at risk of entering the child welfare system. So we've seen some movement, even in a very difficult political climate, in terms of a very polarized Congress. We've seen some movement in the last year in terms of supporting federal legislation supporting children and families. So we think that's illustrative of this of our push in the Unleashing the Power of Prevention report to up the percentage of funds that are allocated towards prevention. We can also look at examples of what states are doing. States are increasingly providing funds that are directed towards prevention. Our best examples right now are coming from marijuana tax dollars from selected states that have legalized marijuana. We're one of them, as you know, and Colorado has in the past several years allocated over $16 million to support 48 new communities that care sites across the state. So that's an example of state funds being allocated towards prevention activities. Washington State, likewise, has allocated $20 million towards prevention partnerships in their state. I think Washington is a good example of a state that got ahead of the curve a little bit and built in some I don't know if they're called guarantees exactly, but structured funding channels towards prevention that result from marijuana tax dollars. Our work in Massachusetts recently has culminated with a report written by a Commission on Behavioral Health Promotion and Upstream Prevention that is recommending that appropriations of no less than 33% or $10 million from cannabis revenues be directed to prevention coalitions, community-based coalitions. They've also integrated pay for success contracts and have developed some innovative ideas around tax credits for local sponsors of evidence-based prevention programs, the latter being kind of an innovative one, I think. So that's being debated in the Massachusetts legislature right now. So those are some examples. Here's a slide showing communities of care sites across Colorado. The blue shaded counties are counties with one CTC site. The darker shaded counties are those having two sites. So you can see that we penetrated across the state quite widely as a result of state funding for this particular initiative. We'll come back to coalitions here. We'll get to coalitions a little more in depth in a moment as well. So, moving along on this action step review and goals, the third is to implement capacity building tools that guide communities to assess and prioritize risk and protective factors, and to select and implement evidence-based prevention programs that target those factors. So we've set three goals here in the next decade that at least 1,000 U.S. communities will actively monitor population levels of risk and protection. Two, that communities will implement effective health promotion approaches and evidence-based interventions. And three, that 1,000 communities will have a coalition of stakeholders who actively monitor the reach and fidelity of a comprehensive system of prevention programs. Those are lofty goals. Let me share with you what we think is some progress that align with each of those goals. So first, the notion that 1,000 communities will actively monitor population levels of risk and protection. This really comes down to states, for the most part, taking on the responsibility and the long-term commitment of measuring risk and protective factors in young people through school and surveys, through statewide surveys. We have some data from the Bach-Harrison group in Salt Lake City who has contracts. It's a survey research group out of Salt Lake that does extensive work in states across the country in terms of measuring, implementing statewide risk and protection surveys. In Colorado, we have the Healthy Kids Survey that is an example of this kind of work. So we can report 20 to 30 states that are currently using statewide surveys that include measures of risk and protective factors, many of these from the Communities That Care Youth Survey, or also known as the Prevention Needs Assessment Survey. So we see some progress in states and communities embracing this idea or getting behind this idea of risk and protection and understanding risk and protection at the local level with the intent then of selecting programs that target those risk and protective factors. We've also made progress in Goal 2, which highlights the importance or states the importance of implementing and selecting and implementing tested and effective prevention programs. So we know that many of the programs on the Blueprints Registry, for example, are being implemented across the country. One thing we don't know real well, when David and I worked on this a bit last week, was trying to get a clear understanding of the reach of those programs. How many communities are actually using programs that are listed on the Blueprints Registry, for example? Do we really know the penetration, so to speak, of all these programs across the country? And we think that compiling that data would be important for us as a selling point, as an impact point going forward with funders and with legislators and so forth. So just what is the reach? We have some data from Pennsylvania suggesting that 327 Blueprints programs were implemented in that state between 1998 and 2018. Gil Botman graciously provided us some data last week on the impact of life skills training. Life skills training is primarily a school-based intervention that is now across the country in a number of sites and reaches a wide developmental age range. And this slide shows an increase in communities using life skills training between 2014 and 2017, and you'll see two bars here for each year. On the light shaded one are the number of cities, and the dark shaded bar is the number of zip codes. So this really reflects data that comes from the distribution of life skills training, or the requests made to purchase life skills training, the subsequent mailings of life skills training to communities across the country. So we can say in 2017 that about 1,000 communities are using life skills training, slightly higher number of zip codes if we organize the information by that. So certainly this is impressive, and it's an indicator of the reach of life skills training as a universal prevention program in the country. But as Gil noted to me, it still leaves us at only about 5% of the nation's schools and communities. So we still are at that low bar despite the reach of one of our most well-known programs. So back to that earlier point on the impact and the reach of our programs, we think it's critical that we monitor the actual implementation and how widely each of our tested and effective programs are being used, so we can use that data to increase impact and interest at a public policy level. Let me turn to our third goal in this action step, and that is to increase or to, in the next decade, see 1,000 communities having a coalition of stakeholders who actively monitor prevention activities. This relates to really prevention systems. We now have two tested and effective prevention systems that help communities organize their prevention efforts in the country. One is the Communities That Care that I mentioned earlier. I know there are sessions on Communities That Care that many of you will be likely attending at this conference. The second is known as Prosper, developed by Dick Spoth at Iowa State University. Communities That Care, if we look at, again, what we're trying to do with these progress markers are to note its reach. So the question becomes, how many communities are Communities That Care and Prosper currently in the United States? So we've got some estimates here, trying to reach this goal of 1,000 communities. We know there were 120 original CTC sites. There's currently 117 communities using CTC Plus, which is a new version of CTC that incorporates online training and other forms of online interaction. We know that's active in 13 states. I think we're not counting here other sites that are active around the world. We know there are CTC sites in Europe. There are some people from Malmö, Sweden here in the audience that are representing their local coalition, I know, and there are others across Europe and Australia and other parts of the country. So we need a little more accurate count of that, but that gives you some indication of its reach. Dix reports currently 64 Prosper sites in the country that are in 2017. Pennsylvania reported 67 coalitions in 2017. So it gives you a little sense of how far we've come in impact in terms of its reach. Another form of coalitions we can think about are those that are federally supported. And since 1998, the Office of National Drug Control Policy has awarded more than 2,000 drug-free community grants in all 50 states, actually, many of these operating on a coalition kind of structure. There were 719 of those awards in 2017, only 120 in 2018. So that's another form of coalition. One thing we don't know about those federally supported coalitions are how many of those are actually using a tested and effective coalition system. Are they incorporating CTC? Are they incorporating Prosper? We don't really know the answer to that. But we have seen significant progress really in the number of communities that are using this coalition system as a way of organizing and promoting their prevention efforts. Okay, action step 4. I hope you're still with me. I know I'm going through a lot of these different steps, so I'll try to make sense of each in turn, and then I'm going to put them back up again later so you can revisit them. 4, we thought it's very important to develop and increase public awareness of the advances and cost savings of preventive interventions. Probably goes without saying. We have a goal that all 50 states in the next decade will use outcome data from controlled studies and information from cost-benefit analyses to inform their policy decisions. We have seen progress here. One is this is the work that is represented in this conference and what we're doing here today, and that's the Blueprints Registry. It provides a really important source of information of tested and effective programs that meet the highest scientific standards. States have used the registry to inform their decision-making about the rollout of prevention programs. Pennsylvania, I've noted here in the slide as one example. Blueprints it's hard to really understate the accomplishments that have come through the Blueprints Registry, really. We're looking at a set of tested and effective programs that have been vetted by experts. These are programs that contain manuals. They're ready for implementation and ready for use in communities and in a variety of school and family and community settings. So the accomplishments are really laudatory. And certainly our coalition and other groups that are out there working to promote prevention are constantly referring people back to the Blueprints Registry. So we've seen that penetrate the field in very significant ways. On a similar basis, I think we can point to the Washington State Public Policy Institute for its work on cost-benefit analyses of prevention programs. I know in Washington State they've been using The legislature there has been relying on what's called, the short name for this is WISIP, the Institute. I've been relying on WISIP for information on whether to build prisons, where to put funds in the justice system, how much funding should go to prevention, et cetera. So they've been really relying on this institute in specific ways. There are other entities as well out there. The Pew MacArthur Results First initiative is in 27 states, 10 counties to implement evidence-based decision-making systems in those locations. So these are very significant accomplishments, we think, in our field. And to return just briefly to blueprints, it's as I noted, it provides a registry of tested and effective programs that meet the highest scientific standards. We know that. And as David and I talked about this talk, we wanted to put forward this idea of opportunities. And that is that should we consider, we collectively, the field, making blueprints, criteria, and scoring system the national standard for all registries. We know there are a number of registries, and I think there are some talks here at the conference comparing and contrasting different registries that list effective programs. I guess you can see our bias towards the Blueprints Registry as the place to go for information about effective programs. Another thing to consider, establishing blueprints as the source of information for SAMHSA, CDC, and drug-free communities using the strategic prevention framework. We know that many of you are likely have been familiar with the national registry that SAMHSA has run for some years, known as NREP. It's now been shut down. We think blueprints is the logical substitute for SAMHSA, for example, and should be viewed in that perspective or from that point of view. And finally, consider making blueprints the criteria, the standard, the blueprints criteria, the standard for your state. So these are some directions we'd like to see going forward and considered for the Blueprints program. Oops, wrong way. Okay, action step 5, increase infrastructure. We know one thing we've certainly learned in the last decade or two is that it's not only important to convey information about tested and effective programs to state legislators, to policymakers, to practitioners, but that it's also, it has to come with, that information and that conveyance has to come with infrastructure to support the delivery of those programs. We know that's an essential key. It's not good enough to look at a list and to see that there are programs, but we need to take the next steps to really develop the tools, the technical assistance, the supports to implement those programs at the ground level. So we think it's important that states, for example, have what many people refer to as intermediary organizations that support the implementation of effective and prevention programs. And there are examples at the state level, and there are other types of examples too. At the state level, we've seen the best known one developed out of Pennsylvania State University, known as the Epicenter, which was created in the late 90s to support the uptake of prevention programs across the state of Pennsylvania. There are several other examples listed here from Massachusetts and Connecticut. The University of Maryland has an Institute for Innovation and Implementation. In Colorado, our own Department of Public Health and Environment has a very active CTC coaching system that operates in this kind of fashion. So you can see there's a combination of supports and here for this type of support. We can also look at other organizations that are located not at the state level, as an example being our own Invest in Kids program that Lisa Hill directs, that provides support for the implementation of the Nurse-Family Partnership and the Incredible Years programs. That's another form of what we're thinking of as backbone support for the implementation of preventive interventions. At the University of Denver, we have something called the Center for Effective Interventions that's in its earlier stages, but that has been working hard on the implementation and the coaching and leadership of MST programs in the Intermountain West. So there are these different examples, and we think these are important steps. I've also listed Pew MacArthur here again as they're providing infrastructure support as well. And there are likely others out there that we could identify. Okay, 6, monitor and increase access of children, youth, and young adults. This goal gets at what people have, especially in state systems, have long been interested in and, to my knowledge, haven't solved. And that's the idea of creating integrated data structures or sharing data across systems of care. So we have, in most states, we have child welfare systems, disability, education, employment, health, justice, so on. These systems tend to be quite siloed, and it's been a long-standing, I guess, dream of many people who work in these systems to be able to share data across those systems, and with the goal of being able to use that shared data to better develop a continuum of integrated prevention and treatment programs. A second part of this, having achieved that, the ability then to actually disaggregate some of this shared data so local communities can use data more effectively to make decisions that pertain to them. So, progress. We just said, help us. We don't know. What has been done in this area? If significant advances have been made, it's a complex problem. I know we've talked about it a lot over the years, and to my knowledge, haven't really solved this one. So maybe some of you have some ideas when we get together and talk informally at the tables on this one. Another goal is to, in unleashing the power of prevention related to this step, is using technology assistant approaches. Now, this is starting to happen through several investigators using apps, collecting social network data through apps, infusing technology in preventive interventions. We've identified a few investigators that we're familiar with that are doing this across the country. I've listed them here. I suspect we're missing, maybe some of you are involved in those kind of innovative approaches. We'd love to hear more about that in the future. And the last action step is to prepare the workforce. So we know that it's critical that we continue to have a pipeline of practitioners, people interested in policy and policy development and analysis, as well as research in our field to keep the momentum of prevention and going and to advance prevention. So we have goals related to that relate more to the educational mission and having, for example, cross-disciplinary prevention training programs in universities, curricula in universities that address prevention. I'm in a school of social work, as just to illustrate one example. Schools of social work you would think would be teaching a great deal of prevention content, and actually that's not the case at all. We really have focused much more greatly on remediation and treatment, and while important, it has been somewhat of a detour from the origins of social work, which really had much more to do with community organizing and prevention than it does today. So that's one of my crusades in my own field. But we have seen progress. We have seen progress in an increase in these programs. We did a quick search last week and found some 15 to 20 universities that are offering PhDs or masters, or about 15 of those in prevention science, some form of prevention science program. We think this is important and something that we hope will continue and expect that it will. So that's, I know a lot of information, a lot of action steps, a lot of goals. I hope those make some sense as I've rolled those out, and that you've got a flavor of the 7 kind of key areas we think are critical in advancing our field. So I'd like to take a few moments now and ask you to do a little work at your table or in partners or in pairs, whatever kind of works here. We're a big room, so you can kind of huddle together, I hope. All prevention people are generally good at that, so I'll let you figure that out. And think about what you can do to help unleash the power of prevention. So I'd like you to share your ideas with a person next to you or a small group next to you. It won't take a lot of time, maybe 5 minutes or so. How are we doing here? Yeah, maybe 5 to 7 minutes, something like that. I'll call you back. Decide on a way that you can help. And I'm going to put back up on the screen in a second here those 7 action steps for you to look at as you engage in a little bit of discussion. And I'd love to hear from some of you afterwards. It's a big room with a lot of people, so we won't go around. But if some of you have some great ideas, I'd love to hear a couple report back on ways that you think you can help. I put up a couple examples of those ideas that we thought about. For example, you might be interested in encouraging your school district, your community, or your state to use a survey that measures risk and protection. We talked about the importance of that in one of the action steps. Encouraging your state to adopt blueprint standards as a guide for funding. As another example. Provide effective preventive interventions through established channels as another example. I didn't talk about this today, but we have a group within our coalition for the promotion of behavioral health who's quite interested and is working on the idea of co-locating tested and effective family prevention programs in primary care settings. We think there's an opportunity there. We think there's a real logic to that, to locating those programs in primary care settings and partnering with the medical field to do so. Those are examples. So if you would, let me give you 5 or so minutes, maybe a little longer, and talk about these ways in which you could become involved or what you see yourself as being able to contribute to one of these 7 action steps. And I've put those up on the slide now. Thanks.
danced and life was smiling. We were young and drunk in love. A few years later I started thinking, if it's just love in every glass I'm drinking, we're like one and without you I'm sinking. I'm always shining next to you. Oh, I got you, there's no reason to chasing pavement on my own, 'cause you're here to stay every night and day. I'm delighted 'cause I got you.
I have always been afraid of changes, but you show me life is full of faces. Sometimes clouds got in our favorite places, but we were young and unaware.
Oh, I got you, there's no reason to chasing pavement on my own, 'cause you're here to stay every night and day. I'm delighted 'cause I got you. La 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 la. La 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 la. La 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 la. I'm just fine 'cause I got you. Rain got in my way before, pouring like a waterfall. I cried a million tears and more to find out where I belong. We're not young, but we're still free and running, and this day has never kept us bothering. Every day we dance and life's been smiling. We're not young, still drunk in love. Oh, I got you, there's no reason to chasing pavement on my own, 'cause you're here to stay every night and day. I'm delighted 'cause I got you. La 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 la. La 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 la. La 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 la. Time is up, nothing to do.
Let me just give you a minute or two to wrap up, and we'll get back together for a debrief here. So I'll be back in a couple of minutes. Okay, if I could interrupt your conversation and get us back together. Sounds like a lot of good conversations going on at the table. So let me ask if we have a couple of microphones that can float around the room here. I think people are ready to do that. If we could have just a couple of people report back on anything that excited them, anything that your group thought you could do to help unleash the power of prevention. Can we get a volunteer somewhere out there? Anybody? Start us out. Yeah, back in the back there. See, is there a microphone? There you go. Is that on? I guess the mic needs to be turned on. No? You want to run up here? You could. Not sure what's happening there. No. We're trying to unleash the power of the microphone here, but we're having a little trouble. Are you there now? Yeah, there you go. Okay. What is your group thinking about?
Stephanie Bradley, I'm the director of the Epicenter, is sitting here with
Oh, great. Yeah, Stephanie.
founding director, having a great conversation about all the great, of course, suggestions in the Unleashing the Power report itself. And one of the things that we're actually going to be focusing on in the next couple of years is around developing a training institute where we are able to address some of the workforce development needs that exist with our practitioners. So definitely we recognize the need for those graduate training programs, but also trying to address the capacity building needs of the existing workforce itself. So those folks who are going to be mentors to the students coming out of those programs, and really trying to help focus on building general capacity for understanding prevention, understanding evidence, what is fidelity, monitoring, why does it matter, and then also working to address model-specific capacity. So if we're talking about CTC or life skills training or those specific type of programs, understanding what's needed at a practitioner level to sort of continue to strengthen that workforce.
Great. Great. That'd be a really important development for the field. That's wonderful to hear that you're going to go in that direction. Thanks, Stephanie. Others? we get another report back out. Don't be shy. I'm sure you talked about some important things at your group. Lisa, you want to just come up, or let's see, we have someone up front. There she comes, I think.
Good morning, Lisa Hill with Investing Kids, and I was just acknowledging at our table the important work that Colorado is doing to ensure that the commitment that our Governor Hickenlooper has made over the last 8 years is maintained in future administrations, and the vision of the governor's office, joined by many folks in the private sector as well as those in different agencies in our state, is retained. And so we have a group called the Evidence-Based Policy Collaborative who's been meeting both with the governor's office but also with a bunch of us that sit outside of state government. And how is it that we want to put forth a strategic plan that lends itself to continuation of this work even as the administration turns over, given how much progress we've made. And it occurred to me in hearing your presentation that you have already done a tremendous amount of the work that will allow for us to be just that much more thoughtful and sophisticated about what we put forth as our intentions through the coming years. So we're very excited that you have done a lot of the work for us, and that our strategic plan is only in its infancy, and we will benefit greatly from what you've set forth in this work.
Well, great, thanks. And that is a really important issue, is sustaining programs. I was talking to this group from New York, and they're going to talk right now, actually, about this issue as well. So, no, go ahead. No, you say it better than me.
I'm Deborah Rubian. I'm with New York City Administration for Children's Services, and in our city we have implemented 10 different models of evidence-based, evidence-informed, and promising practices in our system, and we have sustained them for the last 5 years. And our foster care rolls are decreasing, partially because of this. So we're very, very pleased. So we are glad to bring child welfare more to the table and to the forefront. We have some questions about when models are producing their adaptations somewhat towards the New York City roles and our system and what that looks like. And we also want to hear more about what is needed to sustain a model 5 years out. That it takes a lot, and what we have learned from implementation science, that we respect all the research that's been done, but the implementation of even models that perhaps had less efficacious results, if it's implemented well and then sustained on an ongoing basis, that the results come out and the outcomes are good.
Yeah. Great. Those are equally important issues: adaptation, the sustaining of programs over the long haul, the training of people to deliver programs with skill. All those are intertwined issues that are really critical. I think we're down to about a minute here, so is there one more, maybe one more over here, and then we'll have to continue out in the hall, I guess. Or where was it? I'm sorry, was it? Yeah, she's over.
I think it's working.
Okay, all right.
I think another really important step that we need to think about is how to increase the range and depth of engagement of youth, families, and communities in the actual implementation, step up, and evaluation process of our evidence-based programs. I think it's really important to keep that voice and role of the people we're serving in our communities in the entire process, not just in terms of people that we serve, but in terms of taking on leadership roles as well.
Yeah. Okay, good. That speaks to the importance of coalitions and the coalition work that's certainly going on, very compatible. Well, thank you very much. I think we have to come to an end. Have a great conference. There's many good sessions that'll pick up on this one, and thanks again.
I just want to thank Jeff again for stepping in, and it's fortunate we had, again, one of the prime movers in this initiative. So we're very fortunate in having somebody with all the skill and techniques and all the experience that Jeff brought to this discussion. All right, so we're done with this first keynote address. It's time for a break, and from the break, go right directly to your first sessions for the morning. Thank you.